Our genetic disorder is Smith-Lemli-Opitz syndrome, from here on referred to as Slos. Slos is a genetic autosomal recessive disorder, which means that the affected individual is the offspring of two people who do not have the disorder but are carriers for the trait, meaning they only have one copy of the trait. However, when reproduction occurs, there is a 2 in 4 chance that their offspring have the genetic disorder that they carry. Slos is characterized at birth by a cleft palate, genital deformation, a small head, extra fingers or toes, webbing between fingers or toes, drooping eyelids, hearing or sight loss, and/or difficulty feeding. Infants with severe Slos may also suffer from heart defects and kidney disease, causing death in the first months of life. Slos occurs in 1 in 20,000 to 60,000 live births in the United States, while many affected fetuses are stillborn. The disorder has been known to be more common in people of European descent, specifically Slovakia and Czechia. However, the disorder is significantly less present in those of African and Asian descent. Slos affects males and females equally. However, females are often not diagnosed because they do not exhibit the visible genital abnormalities that are characteristic of Slos in males. The diagnosis of Slos is based on physical findings and detection of an elevated concentration of 7-dehydrocholesterol, or 7-DHC, in blood serum, or an elevated 7-DHC to cholesterol ratio. The disorder is caused by deficient activity of 7-dehydrocholesterol reductase, which is an enzyme that catalyzes the final step of the cholesterol biosynthesis pathway. This step involves the reduction of delta-7 double bond of 7-dehydrocholesterol in order to produce cholesterol. The decreased function of this enzyme results in high levels of 7-dehydrocholesterol, high levels of isoprenoids, and low levels of cholesterol. Chromosomal mapping experiments localize the gene that causes the disorder to chromosome 11q13. However, more than 130 mutations to DHCR7 gene have been identified in Slos patients, including missense, nonsense, and splice site mutations. A splice site mutation in intron 8 of the DHCR7 gene has been accounted for in 1/3 of Slos mutations, making it the most frequent mutation. This mutation, along with 5 other mutations, accounts for greater than 60% of all Slos mutations. These mutations include a cysteine for arginine substitution at amino acid 404, identified as the R404 mutation, a methionine for threonine substitution at amino acid 93, identified as the T93M mutation, a leucine for valine substitution at amino acid 362, identified as the V362L mutation, a nonsense mutation at amino acid 151 resulting in termination of translation, identified as the W151X mutation. Another resource stated that a G to C transversion in the splice acceptor site of exon 9, IVS8-1 G to C, was suspected to be a frequent mutation, having been detected in about 18% of Slos patients so far. This mutation results in the elimination of an ALWN1 restriction endonuclease site. When these mutations occur, cholesterol is unable to synthesize, and that leads to other problems within the body. Sonic hedgehog, called SHH, is a protein modified by cholesterol addition that is necessary for patterning events that take place in the central nervous system, during limb development, and in the formation of facial structures. Altered levels of cholesterol in individuals with Slos affect the normal physiochemical process of cell membranes due to the role of cholesterol in overall membrane function. One major defect results from reduced membrane cholesterol is an inability to form ordered lipid domains. These lipid domains are necessary for normal signal transduction. Currently, there is no cure for Slos patients. The primary form of treatment involves cholesterol supplements as well as rich cholesterol diet. Statins, which are HMG-CoA reductase inhibitors used as lipid-lowering medications, have been suggested as possible treatment because they are expected to lower 7-DHC concentrations. However, further research is necessary to determine if statins can be used for Slos therapy. Cholesterol supplementation is a logical treatment because it may be expected to raise plasma and tissue cholesterol levels. Adding cholesterol may reduce levels of 7-DHC and related cholesterol intermediates that may be toxic by feedback inhibition of hydroxymethylglutarol coenzyme A reductase. Inhibiting HMG-CoA-R is expected to lower levels of 7-DHC and therefore decrease flux through the cholesterol synthetic pathway.